enough of chronic stuff usually because there's a gradual buildup of plaque over time. However, often when we're looking at stuff happening, it's an acute exacerbation of that state. It's a sudden kind of onset, but it's usually based off of a long-term development of plaque. So chronic CAD, we're gonna, so these are people that have had heart attacks and repeatedly have heart attacks and stuff like that, that we're following up later and later. So this is going to include things like aneurysms. We'll talk about pseudoaneurysms, chronic remodeling, so that shaping differences as it becomes weakened and scarred. Chronic ischemic dysfunction or ischemic cardiomyopathy, functional mitral regurgitation, and chronic RV dysfunction. So we talked about some of that already, but now we're talking more long-term because of sort of repetitive incidents. Okay, so aneurysms. So what is an aneurysm generally speaking? What have we talked about aneurysms already?
Isn't that an outpouching of the vessel wall?
Yes, it is. So fundamentally what's happening is we've got a weakened wall of some kind. So usually aneurysms happen, particularly we talked about Marfan's patients, for example. So Marfan's patient has connective tissue disorders that makes the structure of the walls of the vessels weak, and therefore they stretch like a balloon and they sort of pouch out. And same thing happens in the heart. So think of the heart really as an extension. I mean, the vasculature is truly an extension of the heart. The heart is a more specialized set of cells in the vascular system. You know, it has muscular walls just like the arteries does. They're only thicker. It has an endocardium, which is that inner lining. It has the pericardium on the outside, which is that adventitial type of lining. So it's really a specialized part of the vascular system. So it's going to have similar properties to that. So when that muscle gets weakened and then we've got the pressure, of course, inside it, that all sort of causes it to do these expansions, which becomes an aneurysm. Okay, the risk of any aneurysm, no matter where it is stagnating the flow, which can cause blood clots, and secondly, the stretching can cause rupture to occur as well. So those things are dangerous in the vascular system. They're also dangerous in the heart. I would say that these things are typically more dangerous in the heart because the heart additionally is creating that pumping action and creating higher pressures. It is the cause of all the pressures through the body. So, so it is quite potentially dangerous. So historically, they developed after 40%. So about 40% of them are anterior and about 20% of them are posterior, typically. Why that is, I'm not entirely sure, other than the LAD seems to be one of the arteries that's likely affected. Aneurysms are usually a distinct break in the geometry. So we normally have our roundish shape, and then all of a sudden you get the outpouching beyond that that seems to change the shape a little bit and how that would go around the structure as we're looking at it. So we're looking for that break in geometry or sort of an odd shape. Okay, talking about left ventricle usually, but right can be affected as well. It's going to affect it in both systole and in diastole. And again, that's the myocardium is essentially replaced with scar tissue or fibrous type of tissue. Does not occur after transmural infarction. I'm not sure if I like that statement, but you can ignore that. 6 weeks, we talked about for scar formation to occur. So remember, under 6 weeks is sort of that weak stage, and it was sort of that 24 to 72 hours that we get that geometric shape change. And then you have the weakened walls that during that time is when it starts to stretch and stretch and stretch. It becomes more stable after that 6 week period. Then it starts to form the scars, and that creates more stability, which is good. We want that to be more stable. Its weakest chance of, and the chance of highest chance of rupture is during that stage under the 6 weeks. Usually you can see it in about 1 to 4 days. So again, that 24 to 72 hour period when it becomes weak, that's when you'll start to see that formation of the aneurysm occurring. So it's the earlier stages where it's weak, where we don't have scar formation yet. So remember, once we get scars, it's more stable.
So Scott, it can occur after a transmural infarction then.
Yeah, I don't really like that. I put that in there a couple of years ago. I'm not sure I agree with that statement. So you can just ignore it. I'm not going to test you on it anyway. I would say it would definitely happen after a transmural infarction. I'd have to go back and see why I wrote that. Okay, so resection. What is a resection?
Removal.
Okay, so removal, kind of cutting into and surgically fixing stuff, right? So resection can be done for intractable heart failure and control of arrhythmias. I think that's a typo as well. Basically, if we're having heart failure and we're having arrhythmias and stuff, we can do some fixing of it. So they can, in other words, go in and they can cut out sections of it and kind of gather the tissue back together, sort of like we did with the mitral valve ring. We gather the annular tissue in and the valvular tissue back together and kind of sew it into place. So we can do a resection, cutting out sections of the wall and kind of resewing things together so that we don't have places, for example, where we can develop thrombus, because our biggest concern is thrombus formation, not just the fact that it's not moving. We're never going to fix that territory that's been permanently damaged at all. But we don't want the geometry to get so big and bulky and stuff to where we allow flow to slow down into the thrombose. Aneurysms serve as a good second output for blood ejection. So this is why I put the picture of the balloon on the bottom of somebody squeezing it. You've all seen that happen. You've seen those little toys that have kind of the water stuff in it. It's like a tube that's a plasticky kind of tube, and you squeeze it. Half of it comes out this way, half of it goes out that way. Or the tube of toothpaste, you know, if you're doing it the wrong way, you squeeze the tube of toothpaste in the middle and some of it goes to the back end, some of it goes out where you want it. If you do it the proper way, of course, you take the end of it and squeeze it in, right? My pet peeve, one of them. Resection or kind of restructuring that may be beneficial if it's basal. Typically, they're not going to do it at the apex, but if it's basal, that might have some effect. And then the EF of 35% or a fractional shortening of 18% are measurements to indicate if they are going to benefit from a resection, or greater than that. So if it's like less than 35% EF or less than 18% fractional shortening, those patients may not be helped by doing a resection. Okay, and then pseudoaneurysms. So pseudoaneurysm, if you recall in the vascular, if you have a neck where there's kind of a narrow spot that it comes out and then it goes out into a big bulgy area, or it's actually going beyond the myocardium itself, that's a pseudoaneurysm. So we're looking for kind of a narrow neck of an area where it's leaking between the two areas. And we're looking for that big bulgy area that goes beyond the muscle wall. Okay, it's usually still contained somewhat by the visceral pericardium or the epicardium or at least the pericardial sac, but not actually going into the pericardial sac at this point. So these are a contained rupture of the LV free wall. So if we're talking holes that develop in between the interventricular septum, that's just going to be a VSD. These are leaks that go just beyond the heart, but they're still contained by that last kind of layer that's holding it together. They're contained by thrombus and portions of the epicardium and pericardium. So your visceral pericardium and your epicardium. And that picture at the bottom, I think, is a good representation of this. Let me throw my laser pointer up. Okay, so we're looking at this hole that's developing here. It kind of leaks out. As the blood leaks out, this is not circulation blood, so this is not constantly moving. So you might see some fluid portions of this if you're seeing it fresh, but not too long after. It's stagnant. A lot of this is stagnant flow or stagnant blood, so it starts to thrombose. So you'll start to see formation of thrombus inside them as well. You may still see some flow coming in and out of that if you put colored Doppler or something on it also. Okay. And just like an aneurysm on a vessel, we want to measure the entire outside diameter of everything. So when we're doing the measurement here, what they're showing here is you measure where the fluid is, where the black space is. This is all thrombosed inside here. And so you're actually measuring the true size of it is the entire structure, including the flow and the thrombus. That is important because the bigger it is, the more likely it is to rupture. Just showing a little bit of lumen or flow that's there is not representative of the true issues that we have going on. Okay, so this contained rupture, it's highly probable again of spontaneous rupture. The bigger it is, the more likelihood it is. It's contained again both by those layers and by the thrombus. Okay, so the pseudoaneurysm itself can become locally compressive. So we don't mean being compressed like it's not being compressed, but the mass that it's forming is compressing on the normal cardiac structures around it. So a pseudoaneurysm, especially since we're contained within a sac already, if we hit that outer wall of the pericardium, it doesn't have anywhere else to go. The pressure goes and pushes back towards the heart, and so it can become locally compressive and causing that mass effect on the heart area that is adjacent to as well. Local tamponade can occur. So tamponade again is that racing heart rate. It's going to vary with respiration. And there's the overall tamponade thing we'll talk about is going to become kind of an emergent thing, but it's going to cause some local, in other words, right around that immediate cardiac area, some tamponade type of things like the racing heart. The heart does that on its own and it constricts to try to close that hole off rather than just keeping getting worse. And that will prevent the further hemorrhage or further leakage to go out into the pericardium. And then over time, thrombus forms, creating a weak wall that is that is at risk to rupture spontaneously and often can be fatal. So again, the bigger that gets, the worse the likelihood, or the greater the likelihood of that spontaneously rupturing. Typically, we have that shelf-like appearance. So what do we mean by the shelf-like? Let me go back to the picture. So if we're looking at this on a cardiac image, you see the wall coming around. It's supposed to come around smoothly, and then all of a sudden you see like a shelf, like a sudden, like almost a 90-degree turn there on your flow. We also call that a neck. So in the vascular world, we call that the pseudoaneurysm has a neck that's usually more narrow than the flow itself. Okay. I guess in the cardiac world, they like to call it a shelf. Opening less than the overall dimension. Again, the neck is just suggesting that it's more narrow than the rest of the fluid pocket is outside. The true size is often not seen in echo due to similarity of echo characteristics to the surrounding tissue. So in other words, it can be tough to see for a couple of reasons. It does look like the tissue around it, but we've also got a lot of lung artifact. We've got a lot of rib shadowing and stuff like that gets in our way inherently. And anything that we have outside the heart, we tend to not pay that much attention to because usually we're just happy to see the endocardium and take it EF, right? So at least that's where we're at as students. So paying attention to stuff at the outside of the heart is just as important, but it does tend to blend with the tissues that are around there, so it can be sometimes difficult to see. Okay, I like this picture of it. This is obviously an artist rendering of it, but this is a pseudoaneurysm. You can see that it's taking that last layer of the epicardium and the visceral pericardium, and it's forming a pocket of fluid inside that. Once that ruptures, then it goes out into the regular pericardial sac, which we don't want it to happen. You can see that that muscle had a kind of a tunnel that became through there. This area in particular near the basal section is often very difficult to see too, just because of the rib shadowing and stuff that's coming around our heart that we're looking at. So it can be tough to see. All right. So base of the heart are typically inferior MIs, and they can be difficult to separate between true aneurysms and pseudoaneurysms. And again, part of that reason is that because of the poor axial resolution we have from that perspective, it can be difficult to see. Regardless, we want to prove that there's something going on there, that it's that's not normal, because a pseudoaneurysm or an aneurysm are both bad things. We really only confirm these at surgical inspection or autopsy, so you may not even be able to distinguish them distinctly with echo. It may have to be done surgically. Hopefully not at autopsy, because if we hit an autopsy, we're way too late. Okay, and again, chronic remodeling. So this is just that idea of reshaping the ventricle because of these heart attacks that we've been having, and the weakening in the walls and poor ejection fractions, et cetera, and possible scarring. So these are after transmural MI. The border zone of the MI is typically dysfunctional and susceptible to change. So what do I mean about the border zone? If we have an MI in a very specific location, the areas immediately around, those wall segments immediately around the wall segment that's affected, that is the border zone. And those typically have some dysfunctional stuff going on as well, because it's proximal to the area that was damaged. Okay, so when we look at repeat studies, we're looking to see that it doesn't spread to those areas and make that defect even bigger. We want to try to prevent that from spreading and making it worse. Areas of the MI have varying stages of necrosis, as we've already learned. We also have some tethering effects, some stretching, some stress, even on the normal tissue, causing changes in geometry. So as you can imagine, if we get one small myocardial infarction area, it's going to affect my EF a little bit. If it's the walls around that area are weak, it's going to affect it that much more. It might cause things like mitral regurgitations to occur. That fluid change and hemodynamic changes that we're now experiencing, as you can imagine, over time, that stuff just progressively piles up on itself and becomes worse and worse and worse. So that's what it's suggesting, is that over time, if we don't do anything about it, these tend to get worse and ultimately will end up in heart failure. Chronic remodeling is usually a complication of larger anterior infarction and less often seen in the posterior wall. I think that's just a subjective thing that they've noted over the years. So you'll find that a lot of the heart attacks that you're seeing are quite often anterior wall. You'll see some posterior wall stuff too, but it seems like the dominant one's definitely the left anterior descending. Maybe Darren has some different numbers on that, since they're the CAD folks and they see that directly. Okay, just some diagrams of that. So acute, the acute's going to have a relatively normal shape still. We still got our papillary muscle orientation. You might see that this is hypokinetic, and that may be where it was infarcted. It might even start to get scarred. But initially, early on in time, we basically have a normal shape. And again, over that 24 to 72 hours, it becomes weak and starts to stretch. That's where we start to get this shape here. Again, keeping in the back of your mind, can you make the image look as though it's abnormal when it's in fact normal? And yes, if we're coming from too low of a window, we can certainly make this, I'll call it vertically oblong direction. That can certainly appear that way, but we do have to pay particular attention to the thickening of that wall. So if it's not thickening as well as like the posterior wall is or the inferior wall, that's a note that it might be CAD and not just our angle. So if you're getting that oblong shape, just verify that you're in fact coming perpendicular to the heart the way you should. And then of course, over time, that starts to grow, and even these other walls, because they're tethered to that segment, they'll start to kind of expand out too. So the overall volume and geometry will change in this direction. Okay, so this results in larger LV diameter, which reduces the contractile performance. So remember your Starling's law of the heart. And then we also have a reduction in left ventricular ejection fraction. So as we're taking our Simpsons, that's becoming worse and worse and worse. So again, just to reiterate, the normal ejection fraction is 55 to 65% currently. So you might have something down around 45 to 55%, or somebody who's worse, more extensive disease going to be like 35. But you'll definitely scan patients who have literally like a 15% EF, where there's just like one small little segment even contracting. You're going to see some pretty crazy stuff. Apical displacement of the papillary muscles. Again, I sort of mentioned that already. So as things start to expand out, those papillary muscles are attached mid-portion, but as that expands, it's going further and further away from the mitral annulus and pulling towards the LV apex, which then doesn't allow the mitral valve leaflets to come closed the way they should. And so it's kind of tethering them back based on that. But the important part there is that when they migrate and move, they typically move towards the apex, not towards the base, okay? Which then makes the MR worse. Treatment, studies have been shown that beta blockers or angiotensin converting enzyme blockade may prevent or retard adverse remodeling. So in other words, they found that some manipulation with medications can have some helpfulness on reducing the spread of that defect around the heart. Okay, you don't have to memorize this. I just put up there as the anticoagulation cascade. So you might see some of this from Darren's stuff. Maybe not the exact chart. I just put up there for visual breakup, we'll say. All right, so thrombus. So let's talk about when it does thrombose. Most often it's after a large anterior MI with apical involvement in particular. Apex just makes a little pocket where blood flow gets to go that doesn't have a whole lot of movement inherently. If we had an MI kind of along the midsection or basal section of a wall, there's still a decent amount of movement around there because everything else is pushing from behind it through it. So the apex tends to have more of a pocket formation for that thrombus to occur. So historically, 25 to 40% of patients after their first apical MI develop this mural thrombus. Acute reperfusion strategies have improved it. Historically, the likelihood of embolic events is greatest in the first 2 weeks and then tapered over the next 6 weeks. I'm going to go back to the term acute reperfusion. So what does that mean? Acute means sort of sudden or soon. What is the reperfusion we're talking about?
You're able to
Cath
go in the
lab?
cath lab. Yeah.
Yep. So cath lab, that's actually reopening the vessels, putting a stent in, putting a bypass graft in, whatever we need to there. That's getting the blood to get back into the tissue where it belongs. Yes.
Yeah, I keep reading that it used to be this, it used to be that, but because of the cath lab, we're not seeing these problems like we were.
Yes, and that is fantastic, honestly. And this is why, again, that door to balloon time, this is why when we talk about pediatrics doing these surgeries and stuff that the kids are now getting, they are surviving stuff that would have killed them in the past. So we live in an awesome, awesome time for these interventions to be done. So yeah, it's pretty cool. So mural thrombus, so we talked about on the valves that we sometimes get that endothelialization, remember? So we get that endothelial layer that tends to sometimes grow over things. So with thrombus, with mural thrombus, it's kind of laminar and against the wall, might have this endothelialization that might be happening where that skin, that layer of cells grows over that layer, which kind of protects it and makes it a little bit more stable, which is awesome. I think, so they say presumed because I don't know that they've proven that that's the case, but that's the thought process, is that that's the process that's happening. Because we do know that endothelialization does happen on things like stents and valves and things like that. Again, it's the body's way of kind of protecting itself in a way. So the shape of the thrombus is important. So generally speaking, the flatter it is, the more against the wall it is, the more stable it is. Now, thrombus is never good to have in the heart, but I certainly want a stable thrombus over an unstable thrombus. So 40% chance of embolic event when pedunculated or protruding out into the chamber. So if it's no longer totally against the wall, it's kind of sticking out a little bit, that's a 40% chance of an embolic event happening. That's a pretty high percentage. And where does it go if it breaks off? Systemic, but the one we're definitely concerned about is the brain. So that could be causes of some significant strokes. Okay. Acute thrombus takes on a cystic appearance. So back in the days with vascular and before the systems were good, so in other words, half of the systems in our lab would show thrombus as being basically black. Okay, they wouldn't distinguish very well from your fluid or the blood pool or the lumen. So that acute thrombus formation, you can hardly tell by B mode that it's even there. So sometimes the only way that you could tell is putting on color Doppler and seeing an absence of filling in that section that should be filling. And that's kind of how it used to be. We've gotten better with technologies now, and this is why I'm super cautious about dropping my dynamic range down as a way to make it more contrasty, because then we're getting into that same territory where we're eliminating low-level echoes just because we're dropping our dynamic range. When a better solution would be to keep your dynamic range high so that you can catch the subtleties, but get a higher contrast map. That would be my personal preference. Again, it's not right or wrong per se. It's just that I think that you're keeping more data in the image when you change maps instead of dynamic range. All right. So so the acute thrombus is kind of dark or anechoic. As it starts to thrombose and form, you'll actually see it start to solidify, and it's going to become more and more echogenic. Often it's similar echogenicity to the tissue itself. Sometimes it can become, if it becomes almost scarred, then it can become a little bit brighter than the tissue. It kind of just depends. And so you're just looking at the differences between the walls and the blood pool, and if there's any other shades of gray in those areas that look subtly different from the muscle itself. Okay, you're also looking for wall motion. If the wall is moving really well, I'm not super concerned about thrombus. If the wall is not moving well, even if I don't see a thrombus, I'm concerned about thrombus. Okay. So we must distinguish between thrombus and a true cyst or a mass, because we haven't got to the mass chapter yet, but do we have the chance of having a mass or a tumor there? Absolutely, or a cyst. Okay, so anything that's abnormal that looks like it's an abnormal contour to the walls, abnormal echogenicity compared to the walls, or into the fluid, the same thing. We want to try to note what's going on and distinguish what it is. Now, back in the day, the only time that you really saw spontaneous contrast was when we had a significant slowing down of the flow, and then you could start to see the blood kind of move around. We call that the rouleau effect or the smoke effect. Okay, and you do see that, and particularly on the new equipment, you can see that with normal blood flow. And that's just because, again, we're scanning now with higher resolution transducers. We have higher frequencies. We have great axial and better lateral resolution. And so now we're starting to see that flow that's forming. Remember, the rouleau effect is the idea of it's like a stack of coins. And the idea is that the red blood cells are kind of stacking on each other, creating that higher reflective surface compared to a single cell by itself. But it's actually quite common to see spontaneous contrast. But the more that happens, the more concerned we are about thrombus formation. In fact, when I was in the vascular scanning, one thing that I just noted, it wasn't really taught to me this way, but I feel like there's kind of a correlation with somebody, if you're looking for a DVT, for example, when you compress the vessel, it's supposed to compress and kind of just rebound pretty rapidly. I found that people that were likely to thrombose, that it was kind of what I call sticky. So I'd press it down and then I'd release it, and it kind of hangs for a second and then kind of pops those vessels. And I think that's kind of a early sign of thrombus formation. If you get those kind of sticky vessels like that, that kind of stick together momentarily, that's kind of what we're looking at, because normally they just rebound immediately. I haven't written any scientific papers on that. It's just my Scott's philosophy. I've lost philosophy. All right. So again, when we're looking at stuff, we want to use again, because we can see the smoke effect on these newer transducers and stuff, it comes back to the optimization of your system. So higher frequencies will give us better resolution overall. We have optimized color Doppler, and we also can use contrast or the echo enhancing agents to see it. So let me first ask you this. If you are in our lab and we don't have contrast agents to use, what could you do on your ultrasound system to see if there's actually a thrombus in the apex? What do you think you could do on your system to help prove or disprove it? We'll say it's an apical thrombus, and we'll say we're at apical 4, apical 2 chamber. How could you best show that? How can you best optimize your system to prove in the apex that there is or is not thrombus? We don't have contrast available.
I would try changing the B mode maps and the focus up.
Okay.
Decrease the depth.
Yes, that's good. Yeah, so all these things are going to help, but let's think back to our physics and what is the things that gives us the best possible resolution. So depth is definitely one.
Are you saying higher
Harmonics?
frequency?
You're higher.
Frequency, a high frequency as we can get with harmonics. Good. The depth is great. Sometimes we can narrow in, sometimes we're not going to be able to narrow in too much. So we want the highest possible frequency. We can use different maps to differentiate. So, maybe running a clip once you've optimized it, and then you can run through your maps to see if that distinguishes. Because we have to distinguish the grayscale of my muscle wall as opposed to the grayscale of that thing that I'm interested in, and see if there's a grayscale differentiation. So the better resolution we have for that, the better. Focal zone position should definitely be there if you have that available. And then what natural type of contrast do we already have running through the body that we can capitalize on with our ultrasound?
Could you put on like power Doppler?
You could use power Doppler, absolutely, or even just color Doppler. Okay, so with the color Doppler, and I will say this from the perspective of an applications specialist, that most people will never change the frequency in color Doppler, ever. They take whatever the setting is. Why do you think we set the color Doppler the way we do normally? What are we normally looking at in the heart from the apical perspective that we're interested in with color Doppler? Usually valves, right? Are the valves anywhere near the apex? No. Does it take a greater penetration or less penetration to get to the valve? Okay, so it's a lower frequency, greater penetration. So lower frequency means that we're going to have blotchier pixels. It's not going to be as good. If we want detailed pixels and we're within 3 centimeters of the transducer at the apex, you can increase your frequency of color Doppler. Optimize your depth, optimize your focal position, and we have a great natural contrast agent by using color Doppler without having to poke the patient or do anything like that. So in a lab like ours, we could optimize as best we can. And the reason I say that is because I don't want us to always just default to, oh, I'm struggling, I think there might be thrombus, let's do contrast. Okay. Is poking the patient with a needle and putting contrast into them, even though it's a safer contrast, is that something we just want to jump on just because? Okay. So what I'm suggesting is you can use your ultrasound system to prove a lot of things before you even need to use contrast and submit the patient to that potential trauma. You're also increasing the chances of potential infections, and we just don't want to do that unless we have to. So if you can use and optimize your color Doppler, it can be a great tool. And I will say that 99% of techs don't ever do that. They don't ever optimize it when they could. Having said that, you don't have to be the stubborn person that's like, nope, I'm going to get it. I'm not going to do contrast. I don't need to. Use it when it's prudent. But if you don't have access to it, know that it's not the end. You can still do things to help see it better, which is ultimately our job. Okay, good. So as you can see in this image, you can see this thrombus. So when I'm talking about differentiation of the grayscale, This is why just dropping your dynamic range isn't helpful, because I could drop the dynamic range and this muscle here would no longer be subtly different than this tissue here. That's the thrombus, well, not tissue, that's thrombus formation. And then this is the blood flow with the LVO type of contrast, that's left ventricular opacification. Here you can see that it's kind of attached to the wall mostly. It does look like it's a little bit sketchy right there. This one here you can see is peeled off and is coming out into the chamber. Do you think that stands a decent chance of breaking off? Yeah. So this is a dangerous one. This one looks like it's in the right side of the heart. So we got something here. What, from an apical force chamber perspective, what sits in this vicinity that is normal?
Moderator band.
Moderator band, yes. So we need to, if we see something like that, we got to say, are we just seeing the moderator band? But a moderator band is going to have a similar echogenicity to the tissue around it. So you do have to be careful on those a little bit. Good. So, but you get the idea. So you want to see that subtle differentiation, and sometimes that is a very subtle difference between those grayscales. When we're scanning like lymph nodes nowadays, for example, we don't just scan the lymph node, we actually are looking for subtle differences on the echogenicity of the cortex, which is very fine and very difficult to do. You need very high frequency transducers, but we can see masses and things that we didn't used to be able to see masses in. Kelsey, go ahead.
So that image there to the far left, that would be more of your laminar thrombus, and then the middle one is your pedunculated then?
Yeah, I wouldn't call this one pedunculated necessarily. Pedunculated suggests that there's a stalk. It's usually, so like a pseudoaneurysm that has that narrow neck with a stalk. It's not a stalk on a pseudoaneurysm, but on a mass, you'll have a stalk that's more narrow than the mass itself. That's pedunculated. This one's kind of just extending or protruding out into the chamber. Nancy, go ahead.
I always think of pedunculated associated with the pituitary gland, because the pituitary gland sits down in the saddle and then it connects to the brain by that little stalk. It's called a peduncle. So
yep.
Thank you.
So that's a great way to think about it, because that's when you're thinking of masses and tumors, that's exactly what's happening. You got that little narrowy tissue that kind of leads to it. And that narrow tissue is usually where its blood supply is being drawn from as well. When we're talking about masses and tumors, but that's a great thing to think of. Okay, so back to the regurgitation. So in cases of CAD and MI, in particular, the papillary muscles themselves might be necrotic. They might have that apical displacement that we talked about, and that can cause the MR. So does anybody need me to explain any further? I think I've kind of beaten that dead horse a little bit. The fact that those papillary muscles pull away, it's not allowing my normal coaptation to occur. It's kind of restricting it, so it's either tenting or it's not closing at all. Just because you're stretching the annulus, but you're also pulling the chordae tendineae away from the location so that it's not able to shut down like it should. And that's what these diagrams are kind of showing. There's your normal. It is showing flail leaflets and stuff like that. So if a chunk breaks off, this is their rendering of a chunk of the head of the papillary muscle that's come off, is flipping back and forth, etc. So yeah, it kind of depends on that. So it's certainly going to affect the ability of the mitral valve to close. Now again, the mitral valve itself might not have anything wrong with the valve itself. It's just because it's being influenced by the muscle wall that's causing the leak. All right, so the effect is functional shortening of the mitral valve apparatus, reducing coaptation, causes tenting. So the tenting is, again, is where it just touches at the tips of the leaflets and doesn't actually come down and coap like it normally does. It's like a pup tent, like a old Boy Scout days. Infrequently, the mitral annulus is also dilated as a result. And again, that makes a lot of sense because the LV is just getting bigger. Maybe ultimately cause of congestive heart failure. So if we continue to have those bad leaks and stuff like that, and we've got poor wall function, that's going to contribute to congestive heart failure. What do you think congestive heart failure means? What does that term mean to you? Obviously, the heart failure part, heart's going to have issues and stop, right? What does a congestive mean? when you have sinus congestion, what does that mean?
Like
You
it's
get a
back.
whole bunch of stuff backed up into your sinuses, right? So congestive heart failure is just that we got a whole bunch of blood backed up into the heart itself. It's not getting out. It's residually staying there. Maybe it's not thrombosing at this point, but all those things are going to contribute to heart failure. Wouldn't you think that the Starling's law of the heart would kick in and the heart would start squeezing harder and faster, more contractile?
There's a sweet spot.
There's a sweet spot. There's a threshold that, you've all been there when you're hiking or something, or exercising. We all have our different tolerances. For me, it might be, 5 steps, and for others, it might be, 10 miles. We all have our different spot where that's going to be like, nah, I'm done. And the heart's going to try to work harder and faster, but at some point, the heart's going to be overworked. It's going to get burned out, and it's going to give up. Okay, that's what happens. That's why we're concerned about things like congestive heart failure. Now, don't quote me on it, but I've heard in the past that when somebody gets congestive heart failure, that is really a terminal diagnosis. That once they start to get congestive heart failure, they're likely to die within about 5 to 7 years. Okay, again, don't quote me on that, but just knowing that when we see these things, that it's kind of an ominous thing. It's not really going to get much better. We might prevent it from getting worse faster, but it's going to continue. Similar idea with, again, I heard this. I don't have documentation to prove it, but I heard that that women with pregnancy, when they get gestational diabetes, that they're likely to, they'll go through the pregnancy, they'll go back to normal, but likely they'll actually have full-blown diabetes within about 10 to 12 years from that point. So, getting that is a kind of a rude awakening sign for us. And yes, we can make some changes to our lifestyle that would slow that progression. But when we're starting to see signs like congestive heart failure, we want to get serious about it and do things about it if we want to live long, right? Soapbox. All right. All right, so ischemic cardiomyopathy, chronic LV dysfunction due to the sequela of diffuse coronary artery disease. So again, just diffuse just meaning that it's throughout all the coronary arteries. It's likely affecting multiple segments. It's triple vessel type of disease. I'll use my grandpa as an example. I think he had a triple or quadruple bypass, but he had like 8 or 9 like significant stenosis in his coronary arteries, and it was all through. It was definitely diffuse. His bypass is what he had done. Now they're not going to bypass every little tiny segment. Okay, so he had 8 or 9 of them, but they're able to bypass most of those by doing the 3 or I want to say it was 3, a triple bypass, meaning 3 bypasses. So they could bypass the majority of those, but there was 80 and 90% stenosis in different places. Wasn't just 1 or 2. Exclude CHF due to discrete LV aneurysm or acute MI. Think about that statement for a second.
So I'm sorry, is that just saying that because there's an aneurysm or acute MI, does that mean you have congestive heart failure as the cause?
Yeah, congestive heart failure is kind of complicated. It's really a question of, is it the heart itself just getting weak and kind of giving up, or is it because of coronary artery disease? And I think that coronary artery disease often leads to CHF, but you can have CHF independent of coronary artery disease. So because we have specific walls that are damaged, we have aneurysms and acute MIs, I think we're suggesting that coronary heart disease is not the primary cause. You're right. Could they end up in CHF still? Yes. Diffuse LV dysfunction and underlying CAD, there may be a substantial area of non-transmural infarction. Might be clinical evidence for discrete MI. And maybe focal areas or global hypokinesis. So kind of that those middle 2 points there, the diffuse and LV dysfunction. The next point there, I'm not too worried about that. But the point at the bottom I do want to re-emphasize is that there could be multiple, with CAD being the cause of the heart problems, there could be multiple focal spots that are out, regional wall segments that are affected specifically, but it can also be global. So like my grandpa, he could have global dysfunction because of so many stenoses throughout the heart. The flip side of that is so again, if we have, to go back to our point on the prior slide set, if we have regional wall segment abnormalities, we can diagnose that as a CAD issue. Okay, unless it's like a 10-year-old patient. If we have global hypokinesis, we can't say that that's CAD necessarily, because the entire heart is poorly functioning and there could be other causes contributing to that. So with CAD, it can either have focal spots or global. Without CAD, it's going to be typically global. But there's some overlap on the global.
So I have a question, Scott, to help with like the distinction of that topic there. Say
Yeah.
I saw global hypokinesis, but I did see in one wall segment some scarring. So maybe like the border zones were affected due to the chronic nature of it.
Right. Yeah, that's a good point. So if we are seeing scarring or aneurysms or things like that, then yes, that is diagnostic that it's CAD. Yeah.
Thank you.
Because we have regional damage that's permanent. Yeah, so I would agree with that. All right, wow, your cholesterol really has me worried. You might want to actually look at the patient. I put this in there, I kind of laughed because I actually had, and I'm sure I told you about it, but I was doing a debutamine stress echo one time, and the patient started foaming at the mouth and having seizures. And the wife was sitting right behind me, and the nurse and I are like, so how does the EKG look, doc? And he's like, oh, it looks fine. And he just kept looking at the EKG. When he would turn around, like, you might want to look over here. Like, what are we going to do? Like, you're the
And
guy
that there is the reason why I would want a nurse in the room with me.
Oh man, yes. If I'm doing stress echoes, I definitely want at least one other person in the room. I would not want to do stress echoes by myself entirely with treadmill and echo.
Well, I know you mentioned some places actually make the techs do it all themselves, and that just blows my mind.
Yeah, that is putting an immense amount of risk and potential medical malpractice on the line, in my opinion. I don't think I would take a job like that. And I don't think I'll tell you the location that was. I still remember where it was too. But I don't want to stress echo there.
You'll warn us though, right? Like we're not going to clinicals there.
Yeah, you guys are all texting me. It's like, I'm having a heart attack. Where should I go? It wasn't in the immediate area, I'll say that. It was in a different state. All right. Hibernating versus stunning. So I'm not necessarily going to test you on the difference, but I think it's enough of a different terminology that I think you should explore what that means. So can anybody explain to me the difference between hibernation and stunning?
Wasn't stunned the one where like you can use, or the myocardium is still alive, but it was reperfused with enough time?
Yes. So from an echo standpoint, when we're scanning somebody, it could have similar appearance. So both of them suggest that it doesn't rebound back to total normal immediately. Okay, so stunning means that we have some effects that are long lasting because of what had happened. So it's stunned. Whereas hibernating is kind of impending disease that's kind of underlying but not obvious. And when you stress the patient, then it reveals itself. So this myocardium may show evidence of MI, but it's a result of chronic CAD. And it might be subtle until you really stress test it. This could show global hypokinesis, because again, this is usually a chronic, long-term, diffuse disease process. Sometimes it may only show signs of global hypokinesis. Again, that's where our CAD can be global. Debutamine stress echo can be helpful for diagnosis of ischemic etiology. So ischemic, we're suggesting CAD, we're suggesting cutting off the blood supply that's causing the wall motion abnormalities, and not something like a virus or a bacterial infection or something like that. All right, cabbages. I like cabbage. I like coleslaw. For this cabbage, the bypass grafts we use with viable myocardium has the greatest success of reperfusion and recovery. So when they're making a decision to do a cabbage, if there's permanent damage and scarring and stuff already there, it doesn't do any good to bypass that section necessarily, because that's chronic long-term stuff that's not going to be helped. So they're only looking at reperfusing myocardium that they think is going to bounce back and be viable for reperfusion. It is often not possible to separate the ischemic from the non-ischemic dilated cardiomyopathies. Unless they're in like a cath lab. Cath lab gives us proof that there's ischemic processes there, but they may not be doing that at this point. Clues are the patient age and cardiovascular risk factors. So as we get older, it's less and less of a surprise that we've got ischemic processes going on. Again, if I'm talking about that 15-year-old or 10-year-old patient, there's more than likely something that's not a plaque buildup issue. So anybody know what the Framingham risk factors are? Have you ever heard of that? Okay. So Framingham risk factors are a set of information that basically scores the patient's chance of, or the likelihood that the patient will have a heart attack in the next 10 years. So where we use this, the cardiologist will often use it. And Kelsey, where you may have been exposed to it more is the IMT studies, the intimal medial thickness. When we're talking about that plaque buildup process, that goes into play with the Framingham risk factor. So these are things like, their patient history. Do they have high blood pressure? Do they have high cholesterol? Do they have family history, significant family history of things like this? So those sets of data, and you can look up the Framingham risk factors and see how the doctors score them. But what that does tell us is what is the likelihood of that patient having a heart attack or an event in the next 10 years. So that's what that scores. So that helps the doctors to decide if they're going to more aggressively treat that patient, or if they can kind of keep it where it's at or whatever. So in the IMT studies, for example, if it was sort of pre-plaque buildup, where there's no calcification and stuff like that, where it's just thickening of the intima, they found that if they aggressively treat their cholesterols and things, they can actually reduce the size of that and almost reverse the process to some degree. And basically prevent patients from developing any more plaque. Kind of the point. The idea in the IMT studies, we're looking at carotid arteries, the intimal layer, and if it becomes thickened, what it suggests is if we see it in these arteries, it's likely in all arteries, and including the coronary arteries. So this is actually looking at the neck, is giving us an idea of what's happening in the heart. And that's why cardiologists get excited about it, and they usually use that to determine how to aggressively treat, or how aggressively to treat their patients with statins and things like that. Again, detection of scars. To your point, Kelsey, if you're looking at global and you detect a scar, that's a way to make a diagnosis of ischemic disease rather than some other process. All right, so we talked about this yesterday too. Can you see the coronary arteries? The answer is yes. On the transthoracic, we can see them proximally, sort of. It's going to take more optimization. You need the sector size down, better depth, focal position, to get the right frequencies. Those help to optimize the image. You can even stick color Doppler in them and see if they actually go, are coming out of the aorta into those coronaries. We can see their locations coming off. Now we do that with the adult heart to some degree. Pediatrics does that more carefully because in congenital heart disease, these are common issues that, and they can see much better on the kids anyway. You can see the bottom right picture there is from a transesophageal perspective, and they're looking at one of the coronary arteries there that you can see pretty well. So can you visualize plaque inside these arteries? Yeah, if you can see that segment, you can see it. Okay, so so don't think we can't see the coronary arteries. It's just that there's usually so much movement and artifacts and stuff around that we don't see it very well, but we can. Just like that apical thrombus, we just need to optimize our system to see it better. Now we're only going to see into it maybe a centimeter if we're lucky. We're not going to see it right down into the left anterior descending or areas like that. We're definitely not good at that. Variable lengths can be visualized, so it just depends on the patient and what kind of windows we have created as far as how far we can see. And again, TEE is certainly better than transthoracic. All right, peripheral short axis or long axis are best to demonstrate on the TEE. I would say the same with, or that is TTE, transthoracic. In short axis, the left is roughly at a 4 o'clock position and the right is roughly at a 10 o'clock position. Okay, we are looking for those to come off behind their proper coronary cusps. So obviously the right coronary should be coming off of the right coronary cusp, the left should be coming off the left. If it's coming off in an abnormal location, even if you're sitting in an adult echo lab, you should note where it's attaching because that can make a difference on that person's blood supply to the heart. If you notice that. The right one typically sits a little bit more cephalad. What does cephalad mean?
Towards the head.
Towards the head, so it's a little bit closer to the head. So if I'm scanning through it in transverse, if I go a little towards the head, the right one's going to come off a little higher. TEE, the left is easier to see than the right, just simply because it's coming in from behind the heart, from behind that left atrium. It is important to detect, again, if you note those abnormal locations of it bifurcating, then it's important to notice that. But we're also in the segments that we can see. There are things like Kawasaki's disease, not the motorcycle, that actually causes aneurysms to occur and that occurs closer to the heart. So you may actually see a coronary aneurysm even on your transthoracic echo. And obviously, if you see that, you should definitely note it. What is the risk of an aneurysm? What does that do for us? What are we concerned about with an aneurysm?
Ischemic disease.
Okay, so ischemic disease will be there sometimes, but if we got an aneurysm, we're worried about one of two things, and that is rupture or tearing off the intima and having an intimal flap. So those two things are dangerous, particularly when we're that close to the heart. If you can imagine an aneurysm in the abdominal aorta, we'll talk more about that in a different chapter, but if that aneurysm tears, and often it tears at a spot like where there's a plaque buildup or something like that, that sort of agitates it. If that intimal layer tears off, it blocks distal blood supply, right? And so if we're in the coronary arteries and we dissect in that, guess what it cuts off? Blood supply to that entire section of the heart. So those, especially if it's right near the heart. So it's very, very important if you see those aneurysms like Kawasaki's disease would have, then you definitely want to know that. Kawasaki's disease doesn't mean that if they have an aneurysm, they have Kawasaki's, but Kawasaki's makes them predisposed to developing aneurysms. So if somebody has that disease process, you want to pay attention to it. All right, Nancy, go ahead.
I wonder if, because a lot of children are displaying Kawasaki disease from COVID, I wonder how that's going to play out with this,
So
our futures. We might be seeing this more.
You could see a decent, yeah, you could see certainly a spike in numbers in that, and that's a great point. And so if they are being diagnosed with Kawasaki's disease, they have a higher chance of developing these aneurysms. And it's not just in the heart, it's certainly along a lot of the vasculature, but the coronaries are certainly of concern to us. Okay, so variants are important to note if we do see them, particularly again in kids and when we're screening athletes. Part of the reason is, again, if we have one of those anomalous connections, as you guys will talk more about with Mark in the fall, they can cause sudden cardiac death. So, you know, you think that the kid is healthy and they're good, and then they start working out real hard or running or whatever they're doing, and all of a sudden they end up in a heart attack, and you're like, this kid's not supposed to have a heart attack, they're not old enough. It's because of these anomalous connections. So seeing them is very important, because at least if you see them, you can do something about it, or at least counsel the patient on how to have a lifestyle that will work with that. If they're normal, if origins are normal, coronary anomalies are less likely. So if we can prove that those two first branches come off the aorta properly, that rules out a lot of big problems, or at least minimizes the amount that of likelihood that they'll have other anomalies. If both origins are not identified, there is a possibility of having an anomalous origin. It may not just be because you just can't get the window. It may be that you can't get the window because it's not there. You know, that connection is not where you think it is. It might not just be you scanning. Now, as a student, it's natural for us to just assume we don't see it because we suck, right? One that is associated with sudden cardiac death during exercises, the common one is as in the right one, it comes off of the left coronary cusp and then passes between the aorta and the pulmonary artery. That one actually squeezes the artery off, externally compressing it to basically create a heart attack. Okay, and if it's happening there, it's down the entire length of that artery as well. Unlike CAD, where you could have those plaques and stenosis just about anywhere. Kelsey?
So I mentioned this before, but my cousin, I think who is 6 now, she does have a coronary artery anomaly. I'm not sure which one she has. And her mom was asking me if she could be brought in and evaluated, not by myself, because I don't think I could do it, but
Right.
maybe like Tammy, or you said Mark.
Has she been scanned before?
I'm not sure, actually. I should ask that.
I mean, she's diagnosed with it. Chances are, yes, they have. It wouldn't be bad to scan them because I think one of two things: maybe you see it, maybe you don't. But then you could actually see where those are coming off. It might not be this one that we're talking about. It could be a different one. But yeah, Mark or Tamley could certainly scan it. But being that we're a school and we're not really doing this as a true medical exam, you might just ask them first and see if they're willing to do that because they do have a certain amount of liability as a pediatric tech. It can be sketchy.
Okay,
Could we scan it and try? Sure, we're certainly not going to diagnose. But
for sure. Okay.
And Mark may jump on the opportunity like, yeah, heck yeah, I got a kid that I can come in and show you guys what's going on. I think that'd be pretty cool too. And chances are, if they've been scanned, Mark has probably scanned them at some point because everything in this entire area goes there. And there's 4 people in that lab that are full time, and Tammy is their per diem person.
Okay, thank you.
Chances are they've scanned them before, or her. Okay. Again, if you don't see those, if you don't see the connection where it is, I think it is important to note those things. I will say from a general imaging side, I get a little bit sketchy when general techs scan baby hearts and they don't see things very well. The reality is that there's 4 cardiac views that they do. They look for the 4-chamber view. They look at an LVOT, an RVOT, and sometimes a 3-vessel view. So there's 4 cardiac views that they do in general imaging. The hard part is that the anomalies that they're trying to prove, if they're really bad, a lot of general techs don't recognize that it's a bad thing. They just think that, oh, I just don't see it well. So they put not visualized well, even though they may be looking at a huge VSD. They may be looking at a transposition of the great vessels, some bad stuff. They're just like, oh, I just didn't see it very good, so therefore it's not there. It's a little bit of information can be dangerous in some ways, and I have a bit of a struggle with that because I've seen people miss some significant things just because they thought they couldn't see it well, when in fact the disease process was staring them in the face.
Hey,
So,
Scott, isn't there like a certain number that they can go off of when they measure like the LVOT or something when they look at the baby's heart?
they don't actually measure anything. They just show clips. So what they do show, so what they show is a 4-chamber view. So what do you think you see in a 4-chamber view? This is a good discussion.
4 ominous chambers.
Okay, so you see 4 chambers, but when you're looking at those chambers, we're looking at the relative size of those chambers to each other, right? We're looking at the direction on a fetus. We're looking at the direction the heart points in the chest, how much space it takes up in the chest. We're looking at the interventricular septum and interatrial septum, looking for defects. We're looking for proper insertion of the valves, proper size of the chambers. We're looking for pericardial effusions. Okay, so that's a lot of major stuff that you can rule out just on that one picture. Okay. If you do an LVOT, RVOT, what we're really looking for there is to see that they crisscross, because the LVOT goes out this way, the RVOT goes out this way. Right should be on top. So those orientations are important. So if you see them instead coming out parallel, those two vessels, that's what we call a transposition of the great arteries. And they have a different appearance. They come out straight rather than arching and crossing over each other. So they usually do it in a long axis perspective. So they'll take one picture showing the LVOT, the next picture showing the RVOT, not really together. Whereas we would do like a short axis view, where if you see the aorta in the center and the pulmonary going over top of it in the right ventricle, that proves that it has that orientation. So those are things that they can rule out big time. So, by those two views now, I've ruled out transposition of the great arteries, and I've ruled out pericardial effusion, VSDs, tetralogy of Fallot. There's all sorts of different things that I've already ruled out just on two pictures or three pictures. Okay, and then the three vessel view basically shows your pulmonary artery, your IVC, your aorta, and the orientation of those as well. But the hard part is if somebody only knows to get those pictures and they don't really know what they mean, they've missed a whole bunch of potentially huge cardiac problems. And what happens if they saw that view and they saw a massive VSD and they couldn't get their 4-chamber view? So they just like, well, I just didn't see it well. They don't really have a 4-chamber view, or I just didn't see it. They send that patient away. Well, what happens if they have an overriding aorta with a tetralogy of Fallot? These are things that need to be repaired before birth, or you could have, or at least immediately after birth. Otherwise, the child will die. It gets a little sketchy. So my point is, when you're doing these screening type of things, having a little bit more information and digging into it more than what people typically do is a good thing. But yeah, if they see some major anomalies, there's usually some bad stuff. And about 80% of major congenital abnormalities and genetic abnormalities in the babies, including brain stuff, 80% of those have an association with the heart as well. So if they've got some other congenital thing going on, we need to be paying particular attention to the heart, because there's likely something happening there as well.
So do general techs usually catch these cardiac congenital issues pretty good, or is it a situation where they just need to have more education to catch an anomaly?
I personally think that we miss more than we should. There are techs that catch it, but I think a lot of them just take confidence because they're screening techs. I don't know, Kelsey, if you or Sarah, those that have worked in the field, when you're dealing with people that have gone through screenings, how many of those screenings actually caught the disease processes accurately? Did you ever deal with patients that went through screening?
Yeah, like the Lifeline screenings,
Yes.
they were almost always wrong, especially like the ABIs.
So think of it that way. Yeah, it's because often people that are doing them don't have enough education into what they're looking for when it's coming to these specific disease processes. And there's some big stuff that can be missed. And again, when they can show you a good 4-chamber heart when it's normal, but if they can't even get the 4-chamber heart because it's abnormal, they don't recognize that it's abnormal. They just recognize that they can't see it well, like they're used to seeing it. And they might just say something, they can't see it or whatever. And hopefully the radiologist is acute enough to see what's going on and send it to get a fetal echo done properly. But we live in that sketchy world of screening to doing real exams. And sometimes you're going to get things that people flag. In the fetal echo lab, for example, they will do, so the pediatric lab does fetal echo. And I can't tell you how many times one of the soft markers for Down syndrome is an echogenic foci in the heart. And what that is it's usually kind of a calcification on the tip of a papillary muscle. Okay, that comes across as a bright spot. And sometimes we get that simply because we have a really good perpendicular perspective to it, and it just happens to reflect brightly, as opposed to a true echogenic foci, which is an echogenic calcification on the valve. that is a soft marker for Down syndrome. So they get all excited about it. They send them all to the fetal echo lab to get a proper scan done. And most of those are just overcalled. So that's the world we live in. We are a little bit more specialized. We take pride in how good we are at doing the heart, but just realize that others that scan the heart aren't necessarily going to have the same skill set. So it may be good,
For sure.
maybe bad. Yeah, lifeline screening, I think, is a good example of that. What lifeline screening is, just to explain to everybody, is it's a screening place that they do some very, very basic pictures, like 1 or 2 pictures, looking for major abnormalities. So we're looking for like carotid plaque. They might do an IMT study. They might do looking for an aortic aneurysm, and they might take ABIs. That's pretty common. The patient will pay like, I don't know, $150 or something for that service. It's done in like 10 minutes at that. And then they come out thinking, oh, I passed the test, I'm good. Or they thought they found something and they come to the vascular lab and realize that, you know, they completely missed what was going on. And it really comes down to the quality of tech that's scanning it to be astute enough to pick it up. But often they miss stuff that's pretty significant. I had one that came in because of an aneurysm that they found. I mean, you'd have to be crazy to have missed the aneurysm, first of all. They said that the carotids were normal, the ABIs were normal. What else did we do? I can't remember if we did IMTs. Anyway, they had the big, like, severe carotid plaque, at least in one side. I had a patient that had a dissected aorta, okay? And it had dissected down both iliacs, so down both legs. I can't remember if it involved the kidneys or not, but they had significant disease, and the person passed it off as normal for those parts of the study that would have suggested it. It's like, you can have a good tech and they can be great at it, but you can have all sorts of people that know almost nothing about ultrasound and passing off as a good tech. So it's scary. So I got lots of soapbox discussions. Okay, good. So here's a cardiac. So going back to that anomalous connection, this is the cardiac MRI and CT. They are better at seeing these actual connections. So, you know, you can see that these connections are not in their normal locations. And this is, you know, squeezing in between the pulmonary and the aorta. Okay, and if that squeezed off significantly during exercise, we got higher pressure in both of those. That could potentially pinch it off, which is going to, you know, disrupt the blood supply to that entire section of the heart. This is going to supply all the inferior wall. These are just diagrams. These are similar to the types of diagrams you're going to see with Mark. You're going to see lots and lots and lots and lots and lots of these diagrams in the peds section. Pediatrics really comes down to, it's all about the connections. Okay, we don't go as much detail. They do still do stenoses and Doppler measurements and things like that. But it's more about how does this thing connect to that thing. Okay. Okay, just another one, MRI, CT. And then back to Kawasaki's disease. So this is an infectious or inflammatory disease. Okay, as Nancy suggested, this might be something that's coming more prominent with COVID. Typically, it's in childhood. Its manifestations are arthralgia, rash, and fever. It's associated with coronary artery arterial aneurysms. So that's where it's important for us to see these coronary arteries, if we can. Detection with echo is a clinical feature for the diagnosis. So they won't be diagnosed with Kawasaki's until the echo confirms that appearance. Typically seen in the proximal portions, are the ones closest to the aorta, which is why we may see them in the transthoracic views. Might be detected in patients with chest pain, and they can be as large as, yes, 4 to 6 centimeters. Okay, so it would look like you have an aorta coming off your aorta. Okay, that's huge. Okay, usually these are, you know, a few millimeters, 3 or 4 millimeters in size, not 4 to 6 centimeters. Okay. And then direct visualization of the plaque itself. So this is generally speaking in the coronary arteries. Again, yes, if you can see them, particularly with TEE, we can see the chunks of plaque inside there. Calcification and stuff that's there as well. Look for your shadowing. Nitroglycerin and dipyridamole have been used to alter the coronary flow, to use Doppler changes as a marker for the presence of CAD. So they're using that to try to help prove it. Honestly, this is not your standard echo. This is just incidental that they can see this stuff, but there's going to be better tests for these individuals for sure. But you could happen to see them while you're in doing a TED. And that is coronary artery disease. And that leads us into midterm. Yay. So next Tuesday, so bring your questions if you have questions. We're not going to have time to go through everything because there's a lot of chapters. So whatever questions you have and stuff that you want to review, let's tackle that on Tuesday. And then we'll do that. Any other questions today on this stuff?
So our midterm is on next Thursday.
Yes. This quarter is rocking by.
So fast.
Yes. So on these moments where it seems overwhelming, because it does to you and to us, just think back, 3-4 months ago, how much you knew about echo. Okay, just think about how much you dumped in your head, and surprisingly, even how much you remember. That's good. So my point is yes, it's going hard, it's fast, it is like drinking from a fire hose, but you guys are doing well. You're definitely engaged, which makes me happy, and you're learning stuff, which is good. Even though it seems completely overwhelming, you are learning, you are progressing, and that's what we want to see. So, good. Well, it's not quite as sunny today, but at least it's supposed to be up in the 70s. So enjoy your studying for the midterm outside. I know Nancy's already out there.
It's already
Yeah,
pretty
okay.
warm out here.
Nice. Have a
Thank
good
you.
one.
Thank you.
Thank you.
Thank you.